Hi class, this is Dr. Heather Austin Robillard again, and this is a continuance of the risk assessment for this module. But in this lecture video, we're going to focus on some more of the psychological and psychosocial assessment for risk, specifically about harm to ourselves and harm to others. So first we need to review the rights, privacies, and confidentiality and those exemptions that were discussed in ethics. So for example, in some states, harm to self or harm to others might be reportable to the proper authorities. And so we do need to assess for that kind of risk, one, to determine whether we would have to report that, but two, to determine what the best level of care would be. Another exemption would be abuse of a child, elderly, or disabled person. And then in some states, there also are some exemptions for confidentiality when it comes to domestic or sexual violence, sexual exploitation of a therapist, and emergency situations where it might be essential to break confidentiality, as well as valid court orders specifically subpoenaed by the judge. There are some important caveats to remember when it comes to harm to self or others. One, you will typically need additional training in handling these kinds of situations. And usually one session is not enough, and you'll want to use those additional training tools. It's important to consult with your supervisor, as you're not going to be fully licensed once you first apply for the LCDC. You'll need to be working with a team, specifically those that might require this intervention. And remember that you're primarily just working on a screening, so that way you can refer them to the appropriate level of care. Again, we will not be able to talk about all the issues as it relates to harm to self and others, but we're going to kind of give a brief overview. So there are some important things to remember when it comes to assessing for risk of harm. One, it is a myth that talking about suicide will increase or cause suicidality. Substance use is a risk factor for suicide, so it is something that you will commonly come across. The clinician will want to rely on specific instruments, but they are not enough, nor should it be used as the sole basis for clinical decisions when it comes to risk and assessment. There are a lot of different tools for suicide evaluation. Here are some that don't require super specialized training. For example, there are several different types of assessments listed here, and it can kind of tell you the different domains that they have or the accessibility for them. It's important to start with some broad questions. For example, have you ever wished you were dead or wished you could go to sleep and not wake up? And then ask them some follow-up questions. Have you ever had thoughts about killing yourself? Ask them those follow-up questions. You can also use an assessment tool like the Columbia Suicide Severity Rating Scale Screener, which is found in your What to Read folder in this module. Before starting, know the policies and procedures of the specific institution you are in, because they may have specific ways they want you to assess or to follow up if somebody has a suicidal thought. Know the emergency numbers and the number of your supervisor. During and immediately after, make sure you're not panicking and collect all the information that you can think of. Contact a supervisor for the scope of practice especially, and follow your supervisor or your institution's policies and procedures. The typical process for suicide assessment is identifying the risk factors. Risk factors include like substance use, if they've had suicide attempts previously, mental health disorders, and then also identify protective factors, like they have a good social support, they have access to friends and family, and conduct a suicide inquiry to help determine the risk level of this individual, and then determine the appropriate intervention needed that you might need to refer out to for them. The SAFE-T protocol in the Columbia Suicide Severity Rating Scale can be found on a website and is tailored for this purpose. It's very flexible and it incorporates self-report as well as interviewing. It's free, it's short, and it covers a good number of these risk factors. Here's some important things to just be aware of when it comes to factors that may increase risk for suicide. Having trauma, triggering events, specific ideation, medical health concerns, mental health diagnoses, chemical health like substance use disorders, substance use, past suicidal behavior is a high risk factor, and self-injurious behavior like non-suicidal self-injury. If they feel trapped in a situation, purposelessness, hopelessness, withdrawal experiences, anger, recklessness, and mood like anxiety or agitation. Another thing that's associated with suicide is actually being a male or depressed, alcohol and drug-related problems, being separated, widowed, or divorced, social isolation, recent discharge from a psychiatric institution, serious physical illness, recent job loss, current involvement with the police, prison, or certain occupations have a heightened risk for suicide. Factors associated with non-suicidal self-harm are being a female, divorced, under 25 years old, social class like unskilled workers, an overcrowded accommodation, unemployment, debt, or being at your address for less than a year. We also want to identify protective factors when we're assessing for individual risk assessment. Protective factors are those factors that buffer individuals from suicidal thoughts and behavior. They typically aren't studied as much as risk factors, but we do know that they can be beneficial depending on how many risk factors an individual has. Some protective factors for suicidal ideation would be effective clinical care, access to a variety of interventions, connectedness with people, family, and friends, support, skills, specifically skills for problem solving and conflict resolution, cultural and religious beliefs also that discourage suicide. Remember that some protective factors are internal and some protective factors would be external. You might also want to know which of these protective factors can be enhanced. For example, it seems like your auntie is in a bright spot in your life. What, if anything, can change to have more contact with her? This will help increase those protective factors for your client, which might reduce their risk of attempting suicide. When conducting a suicide inquiry, you want to focus on ideation, plan, behavior, and intent. Ideation focuses on frequency, intensity, and duration, as well as now and in the past. A plan is focused on the timing, location, the lethality, and availability and means of their plan, as well as any preparatory acts that they have engaged in. Behavior includes past suicidal attempts or rehearsals, or even non-suicidal self-injurious behavior. An intent is the extent to which they expect to carry out their plan to be lethal versus just harmful. So the risk level for an individual is determined with the previous 3 steps: risk factors, protective factors, and a suicide inquiry. If they have multiple risk factors and there's no protective factors present, their inquiry leads to a potentially lethal suicide attempt, then their risk level would be high. But if they have few or modifiable risk factors, strong protective factors, and thoughts of death but no plan, then it's likely their risk level will be low, and then there's assigned interventions for each of those. Again, it's important to emphasize that we want to recognize the scope of our practice as well as our competency. Technically, we are not going to be trained and liable for preventing somebody from a suicidal ideation, but we do want to get them to the appropriate level of care if we notice this when we're doing a substance abuse evaluation. Next, let's talk about assessment for trauma, because trauma is a risk factor for suicidality and it's often comorbid with individuals who have substance use disorders. Trauma-informed care is, as you remember, a SAMHSA tip number 57. Substance use disorders are often comorbid with trauma or PTSD diagnosis. The assessment for PTSD is beyond our scope of practice, but it's good to document the presence or absence of trauma for potential referral. When you're using a screener and an initial scale for this, you do not want to evaluate when they're intoxicated. Elicit only the information that is necessary for determining the history of the trauma and possible existence of the trauma. You don't want to go into the story of what their trauma is. Present the rationale for asking, and do not open the Pandora's box. We don't want to talk about their trauma. We just want to get the information that will help us know where to refer them. Some screeners might include the Adverse Childhood Experience, or the ACEs, the Trauma History Questionnaire, and the PTSD checklist, specifically for civilians. We also want to assess for possible other risky behaviors or general risks. There tend to be other substance-related risky behaviors, risky sexual behaviors, unprotected sex, and intoxicated behavior risks for HIV. There may even be a proneness to violence, like domestic violence or intimate partner, or something like homelessness or unsafe sex workers. The manner of their drug use, or the type of drug use, like IV drug use or blood diseases, or the potentials for overdose. Remember that a substance use disorder is a big risk factor for some of these things. Other risk factors can include the use of IV and possible transferable blood diseases. Individuals with substance use disorder can often experience homelessness or being victimized, and the development of severe mental health illnesses. That ends this lecture for today. Please make sure you're reading over the required and recommended reading for this module to get more information about these assessment tools. Thank you.